So thank you for handing over the room to us. And so hello, good morning, everyone. At the outset, I'd like to thank AIOC Scientific Committee for giving us this opportunity to present a very interesting and relevant instruction course on corneal imaging, where we are going to explore various devices available in the market and also see how we can clinically apply these in our day-to-day practice. I'd like to thank our eminent speakers for the day who have consented and taken time out from their busy practice to participate in this instruction course. We have Dr. Tushar Grover, who heads the department at Cornea Department at Vision Eye Center in Delhi and has been trained at Narayan Netralaya. We'll shortly be having Dr. Praveen Krishna, who's the Chief of Cornea Department at LV Prasad, Hyderabad, and is a very well-known figure in the country. And we have Dr. Madhu, who is again a very famous cornea surgeon in the country and heads the department at Sri Kiran Institute of Ophthalmology and trained at Arvind Eye Institute at Madurai and at Harvard Eye Institute at Boston. And we also have Dr. Divya, who heads the department at Arvind Eye Hospital, Madurai, and has been trained at Arvind Eye Hospital, Chennai, and has been trained at Arvind Eye Hospital, Madurai. So for the next 60 minutes, we'll be talking on all the relevant imaging devices. And to begin with, I'll on topography and biomechanics, understanding machine integration and learning what you're seeing. Be sharing.
Sir, sorry to interrupt you, sir. You need to share your slide, sir.
Yeah. Are my slides, I hope my slides are visible.
Yes, sir.
All right.
Go ahead.
So the biggest challenge every cornea refractive surgeon come across is patients coming to us wanting LASIK with borderline tomography, and we don't know what to do. We don't know whether to actually go ahead with LASIK or LASIK extra or Smile extra, or to just wait and follow up these patients, or to offer cross-linking. In the literature, it has been shown, and we also come across these patients who has undergone LASIK and has developed ectasia in spite of the ectasia risk score, high ectasia risk score on screening. Many patients are stable post LASIK with recognized ectasia. On the other hand, so to overcome this challenge, we have incorporated in our practice different machines over the period of time. To start with, we were just looking at the anterior surface with the help of corneal topography, and then we incorporated corneal tomography, which used to give corneal both anterior and posterior elevation maps, and then epithelial map and Bowman roughness index, which was described as layered or segmental tomography here. And then later we switched on to biomechanics, which is of interest today. And Boolean microscopy and finite element modeling is still not very clinically practiced. So we'll be talking about biomechanics today. This was a very important contribution from Cynthia Roberts in 2000-2001, where she told cornea is not a piece of plastic, and the cornea exhibits both viscous and elastic properties, which contributes to its biomechanical behavior. Let's understand what is the difference between elasticity and viscosity. So basically, elasticity is the ability of the body to resume its normal shape after deformation, whereas the viscosity doesn't regain the original shape, and there's a dissipation of energy. Biomechanical changes precede morphological changes, and this has been the basis of incorporating biomechanical indices in our practice, because we want to detect these ectasia as early as possible, so to offer patients better safety after all these laser visual correction procedures. So to start with, healthy cornea is there, then it undergoes stress and strain, and then later we'll see a change in elastic modulus, which then over the period of time manifests as biomechanical changes, which can be picked up by newer devices like Corvus ST. Then over a period of time, we'll start seeing these changes in tomography maps, and then over a period of time, it starts manifesting in topography maps, and then slowly we start seeing these patients on slit lamp. So Corvus ST is the most commonly used biomechanical device in the market, and it's a second generation update in this machine. And it's basically a non-contact tonometer that monitors the response of the cornea to an air pressure pulse in real time. It uses an ultra-high speed time-flight technology where the images are captured around 4,000 frames per second. The captured image sequences are then used to estimate the IOP and deformation response parameters. This is one of the display which is shown by, given by Corvus ST, and almost like 16 dynamic corneal response parameters are captured, and you can see how it is displayed here. There's another report which is given by Corvus ST, and it's called Vinciquerra screening report. At the bottom right, you can see some 5 boxes which we are going to talk about. So the DA ratio, integrated radius, and the SPA1 are deformation parameters, whereas the Ambrosio relation thickness is a thickness parameters. And CBI is basically a mix of these parameters, and it shows a color-coded box. So a cornea is stronger or is stiffer when DA ratio and integrated radius is lower, whereas ARTH and SPA1 is higher, then the cornea is supposed to be a stronger and stiffer. Corneal biomechanical index was developed using linear regression analysis for detection of keratoconus with high accuracy. It incorporates 6 deformation parameters along with one thickness parameter, which is called Ambrosio relation thickness. Now, Ambrosio relation thickness parameter was added to a corneal biomechanical index because it was shown that it increases the accuracy of CBI to many-fold. So with a cutoff value of 0.5, CBI has corrected classified around 98% of the keratoconus cases. Let's see an example how CBI can be useful. So if you see on the left side, it's the map shows typical keratoconus, and on the right-hand side, the map doesn't show any changes in favor of even a subclinical keratoconus. But if you see if you see the corneal deformation parameters and CBI, they are all abnormal, as obvious because the cases of keratoconus. Whereas if you see in the right eye, CBI is abnormal, but the maps are normal. So that means these cases are actually could be classified as formifus keratoconus because biomechanical changes are already there. And these are the cases which were missing earlier. This is another update in the Corvus ST where you can see a biomechanical comparison display, which is basically used for the cases where we have done cross-linking and we want to follow these cases. It's a very objective, it gives a very objective results, like all the deformation parameters. They'll give you whether cornea has become stiffer or it's not significant or it has become softer. Also, it also gives the SSI index, which we are going to talk later. And it also shows the cornea has become stiffer in this case. Let's come to tomographic biomechanical index, which is nothing but the integration of biomechanical indices from Corvus ST and tomographic parameters from Pentacam. And together they comprise tomographic biomechanical assessment. So TBI was shown to have highest sensitivity for detecting subclinical ectasia among eyes with normal topography in patients with very asymmetrical ectasia. A cutoff value of 0.35 correctly classified all ectasia cases from formifus to frank keratoconus. If you see an area under the ROC curve here, and when compared to CBI, BAD-D, and TBI, TBI was shown to have maximum area, which just shows that it has the highest sensitivity. This is a typical display from a tomographic biomechanical assessment. You see a TBI, you have a CBI, and you have a BAD-D, and it has a very clear-cut color-coded display. Now let's come to the global consensus on keratoconus. What it says? It says true unilateral keratoconus doesn't exist, but secondary induced ectasia may be caused by a pure mechanical process and can be unilateral. Every day, once in a while, or often, I'll say, we come across patients where we think it's a case of true unilateral keratoconus, but the maps doesn't show anything. So these cases can be classified as very asymmetrical ectasia or very asymmetrical ectasia with normal topography. Let's see an example here. A 17-year-old boy, where you see in the right eye, the map shows keratoconus, and all the parameters like CBI, BAD-D, and TBI also are in favor of keratoconus ectasia. And whereas in the left eye, the Pentacam maps are totally normal, and BAD-D, CBI are all normal. But if you see a TBI, it is elevated. So again, this case can be classified as a case of unilateral ectasia, but since it doesn't exist, so these cases are the cases which can be classified as formic keratoconus or very asymmetrical ectasia. This was a very interesting paper from Ambrosio et al., where they showed subclinical keratoconus detection in identical twins. So if you see on the top, if you see the top photos from twin 1, you see the right eye shows, the map shows, the pentagram map shows signs of keratoconus, and TBI was elevated as expected. Whereas in the left eye, you show the maps, you see the maps are normal, but the pentagram, the bad D is slightly elevated, but TBI is definitely elevated. And if you see twin 2 right eye, the maps looks perfectly normal, except that the TBI is elevated. Whereas the left eye also maps are perfectly normal, but the TBI is elevated. So the first case you can classify again as very asymmetrical ectasia, and the second case, twin 2, can be classified as subclinical keratoconus, which is genetically predisposed to develop keratoconus, but probably it is missing a second hit where the environmental factors are not still present. This is another index which is recently given by Collins Sestri, and it's called stress strain index, and it's a material stiffness parameter. It's a non-invasive measurement of a true biomechanical parameter in vivo. Very importantly, it's independent of IOP and CCP, and it's dependent on age. SSI was taken as 1 for the corneal tissue with age 50, and higher value indicates higher stiffness. So if the curve moves towards the right, it becomes softer. If the curve moves towards left, it becomes the cornea becomes stiffer. And it measures global response and doesn't map the location of the disease. It's not a diagnostic tool. It basically tracks the progression of ectasia. It allows us to decide timely intervention, especially in borderline thickness, especially in pediatric patients. And it monitors the response to therapeutic interventions like CXL, where you'll be able to know whether CXL has become successful or it's a failure. It can be a useful tool to distinguish due to topographic artifacts like ectasia and remodeling. CBI LBC is another new index which has been added, and it's helped differentiate stable post laser visor correction eyes from post laser visor correction ectasia. So basically, till now, what we were doing was all these patients who have undergone LASIK or any refractive procedures, we were trying to see bad D, CBI, and TBI when we are suspecting ectasia. But these indices will always give you abnormal readings because there is a flattening and thinning of corneas in these.
Please wind up.
Yeah, it's just 1 or 2 slides more. So basically, bad D and TBI, CBI in post laser vision correction eyes were giving abnormal reading, and to overcome those challenges, CBI LVC was another indices which was added recently, and it's a purely biomechanical index as it does not include shape or pachymetry indices. A cutoff of 0.2 showed a sensitivity of 93.3 and a specificity of 97.8%. So in summary, I would say biomechanics can become an essential component of the armamentarium of tests for screening of refractive surgery candidates. CBI and or TBI can detect subclinical keratoconus, and SSI is the single most important index for comparing the outcomes of interventions like CXL and LASIK extra. I would like to conclude that integration of the machines for a better diagnostic ability is the way forward, and there cannot be a single index which can definitely distinguish between disease and normal for such a complicated entity. Thank you so much.
Thank you so much, Dr. Ashish Kumar. We now move on to our next speaker. We have Dr. Tushar Grover. So you can unmute yourself.
My gratitude to Dr. Ashish for having me in this wonderful IC. So I'll be starting my presentation. My topic is neuroimaging tools for the assessment of ocular surface. So Dr. Ashish explained really well about the role of biomechanics. I'll be focusing on a slightly different area, which is about the ocular surface and issues like dry eye, which where you had a lot of mismatch between the subjective symptoms and the objective signs. So we now have more objective tools to really evaluate the ocular surface and see what's actually going on there. So I'll be dividing the presentation into
within 12 minutes.
Yeah, I'll do that for sure. So I'll be dividing my presentation into 6 different modalities. And so these include interferometry, meibography, aberrometry, some light scattering properties, non-invasive tear breakup time, and in vivo confocal microscopy. So to begin with, interferometry is basically what helps us visualize the lipid layer of the tear film. The instrument that we use for this is the LipiView 2, but then there are a variety of instruments that are available now which allow us to be able to do that. So what you see here on the left is an individual with a very healthy looking thick lipid layer, and you can see the lipid layer thickness there also is above 100 nanometers. So that's a very healthy lipid layer. But what you see on the right is this individual with a very dull look lipid layer. So you can easily tell by just looking at the image, the interferometric image here, and the lipid layer thickness is also quite low here, which is about 39 nanometers. So this is somebody likely to be having meibomian gland dysfunction, likely to be having evaporative dry eye. And as I said, it has been found that lipid layer thickness correlates quite well with meibomian gland dysfunction. So if you're able to look at the lipid layer, you're able to quantify the extent of meibomian gland disease quite well. Another thing that you get from these interferometers like the LipiView is that you get these images of partial blinks. It will also tell you how many partial blinks an individual is having in the cycle in the duration of the test. So somebody who has a lot of partial blinks, you can go for more intensive lubrication, more viscous lubricants, and more frequent lubricants. The next thing I'll talk about is meibography. So again, this is something which is gaining a lot of prominence. A lot of practitioners have found applications in this. So this helps you visualize the morphology of the meibomian glands quite well. And many of these devices also give you a 3D reconstruction of these glands. So here again, what you see above is somebody with a pretty healthy looking lipid meibomian gland morphology. You can see in the glands, but not much dropouts. Whereas when you look in the image below, you see that that individual has a huge amount of gland dropouts. So that is somebody who's likely been having long-standing chronic meibomian gland dysfunction, which has led to the atrophy of these glands. So this is important to be able to tell because you can base your treatment on that. So we know that when you're treating meibomian gland dysfunction, your first line treatment is warm compresses and manual lid expression. But the issue with these treatments is with just warm compression is that you're not really able to get the optimum temperature at the level of the glands because these glands are at the level of the inner surface of the eyelids, whereas you're applying heat at the external surface, which is why all these expensive modalities like LipiFlow have come about. So the LipiFlow, what it does is it gives heat from the inner surface of the eyelid and gives from the external surface of the eyelids. So you're able to, treat meibomian gland dysfunction a lot better. So this is a 12-minute cycle that lasts. And after that, you get a report at the end of it. And this has been found to be much more efficacious than traditional warm compresses in multiple studies. There are, of course, various other modalities available for the treatment of meibomian gland dysfunction as well. All of them do work well. All of them do involve a cost. They are pretty expensive. So knowing the morphology of the glands helps you decide whether you would want to go for these treatments or not. So somebody who has functional glands is a lot more likely to be able to respond well to treatment. So whereas on the other hand, somebody who has a significant amount of gland dropouts is likely to not respond very well to any treatment, including the LipiFlow. So offering an expensive treatment modality to somebody with significant gland dropouts is probably not the best idea. And this imaging modality helps us identify that. The next modality that I'll be talking about is wavefront aberrometry. So we know that all kinds of dry eye patients with other ocular surface issues as well have aberrations, have distortions in visual quality. So when you look at their higher order aberrations, you can see serial changes in the tear film, in the aberrations of the eye. So somebody who has tear film instability, as in the case of evaporative dry eye, you'd see an upward curve in the post-blink higher order aberrations. So the aberrations would be okay immediately at the time of the blink, but as the tear film evaporates, you'll see increase in the aberrations. Somebody with low tear volume, constantly higher order aberrations at all times. So this is again something that you can document and quantify. What aberrometry, however, is not able to do is to really tell the scattering of the light that is happening. So there are other instruments available for that, such as the HD analyzer, also known as the OCAS, the Optical Quality Analysis System. So what this does is it measures the scattered light. which the aberrometer is not doing. And this uses double pass retinal imaging to provide an objective analysis of the tear film quality as well. So the above image that you see is that of somebody who has a healthy tear film, who does not have dry eye. So you see very minimal scattering happening. Whereas when you look in the image below, that is somebody where you see a step ladder increase in the objective scatter index, which is the scattering of light. So this is an individual with tear film instability, because you see that the scattering is increasing after the blink. These individuals are those who have tear film insufficiency or aqueous deficiency. So you see consistently increased scattering of light, consistently increased objective scatter index in these individuals. So this really gives you a documentation of the quality of vision and the scattering of light that is happening. The next modality that I'll be talking about is called the non-invasive tear breakup time. So all of us do the tear breakup time in our OPDs. We use fluorescein for that, which of course has some limitations. You cannot simultaneously assess tear breakup over the entire cornea, and the accuracy and repeatability at times is suboptimal. So that is replaced by the NIBUT or the non-invasive breakup times. So what happens here is that video keratographic Meyers pseudo discs are reflected onto the cornea, and you see changes in the edge, breaks in the edge of these Meyers happening after a few seconds when the tear breakup happens. So this is what the NIBUT is. And again, so it's a much more objective measure. You can actually watch these Meyers break and document the non-invasive tear breakup time. This has been found to correlate very well with the OSDI scores. This, however, does not correlate very well with different machines. So if you're measuring NIBUT on the keratograph, it might not correlate very well with the ocular surface analyzer, but within one particular machine, it correlates extremely well and is quite repeatable. These machines also give you a measure of the tear meniscus height. So that again has been found to correlate very well with the Schirmer's test value. So a non-invasive way to measure tear film insufficiency or aqueous deficiency in an individual. The last modality that I'll be talking about is in vivo confocal microscopy. So this provides us resolution which is comparable to histological analysis. And the advantage, of course, is that it is non-invasive and real time. So you're able to study the ocular surface and see what is happening at a cellular level in these cases. When you look at this image of an individual with dry eye on the right side and a normal individual on the left side, you see that there are multiple enlarged superficial epithelial cells and loss of superficial epithelial cells in those individuals who have dry eye. What you also see is a dramatic increase of dendritic cells, which are basically inflammatory cells and they're antigen presenting cells. So that again indicates that there is inflammation in the eye secondary to dry eye. There are also a lot of changes that you see in the subbasal nerve plexus in these individuals. In the conjunctiva as well, you see certain changes like the presence of large and more numerous epithelial microcysts on the bulbar conjunctiva. So in terms of clinical applications for confocal microscopy, they are limited, but it really gives us new insights into the etiopathogenesis of dry eye or other ocular surface conditions. So it tells us things which we didn't know earlier. So to summarize, interferometry helps us visualize the lipid layer. Meibography helps us evaluate the meibomian glands and based on that decide our treatment for meibomian gland dysfunction. Wavefront aberrometry and light scattering evaluate visual distortions that are happening secondary to ocular surface abnormalities. Non-invasive tear breakup time is a more accurate, non-invasive and reproducible measure of tear breakup. In vivo confocal microscopy gives us various new insights into understanding dry eye and understanding various ocular surface conditions. Might not be a great clinical tool, but a very, very useful research tool. So there are a whole variety of imaging tools that are available now, which are useful for diagnosis and evaluation of these conditions and that help us guide treatment. And of course, we will never rule out a good clinical evaluation. All of us understand that, but in synergy with that, these instruments are very useful in the management of ocular surface conditions. So thank you. Thanks a lot.
Thank you so much, Doctor. I now request Dr. Praveen to please come in. We have Dr. Praveen with us. Thank you so much, Dr. Prasad.
So,
You
Ashish, do I
can
start?
start sharing your screen. You have 12 minutes for your talk.
Yeah, but then Tushar was very kind to save 2 minutes. So we're going to borrow those 2 minutes. Thank you.
All right then. So are you saying we should put a timer for 14 minutes for you?
Put it for whatever you want.
Thanks.
Anyways, so we will try and finish in 12 to 13 minutes or so. But then again, before I start, really enjoyed both your talks. I was watching them in the background, both Ashish as well as Tushar, and also like the fact that you ended by saying that diagnostics are great, but I think you should continue to build your clinical acumen and skills, because that is probably what is going to tell you about which diagnostic tests you should pick. So to continue on the same vein in diagnostics and what is new, I'm going to be talking about the OCT. So I'll just stop sharing and then share again, just to make sure that the screen is visible. I'm going to be speaking about the OCT. The OCT is not new. Most of you probably already have access to the OCT. And that's the reason why we picked the OCT, because of the fact that this is something that might be relevant to more people in practice as compared to maybe the UBM. I'm not sure if you're able to see my screen. Are you able to see my screen?
Yeah, we are.
It doesn't seem like I'm able to change my. I'm going to stop. I'm going to do it again. Interestingly, I think I'm having some problems with moving my slideshow. So let's see. So in the meantime, I'll just keep talking about the OCT. And the reason why Ashish asked me to speak about two instruments, but I thought OCT probably would be the more relevant one, was because we thought that OCT is something that you can potentially apply to the majority of your patients in the OPD on a daily basis. And that's the importance of thinking about using the OCT. And in the OCTs, I'm going to be covering both the OCTs that are used in the OPD as well as the OCTs that are used in the OR. That is the supine OCT that you can use intraoperatively as well. I'm going to leave out epithelial mapping on OCT because I'm sure Dr. Divya will have an excellent presentation on that. So let's try that again and see if this works. All right, so that seems to be working. So the sequence of what I'll talk about is very little about OCT technology. This actually is a very technical talk, but I can't cover all that in 12 minutes. So very little bit about OCT technology, types of OCTs available, where the OCT imaging really matters, and what clinical applications you can use the OCT for. So from our understanding of OCT technology, you'll be surprised to know that the OCT is not something that is confined to ophthalmology. In fact, OCT technology is quite widespread in several different fields, including in research into vascular growth in carcinomas. It is used widespread in looking at vascular endothelium and also about endothelium of the gut, as well as used by CTVS surgeons for stenting of blood vessels and to look at the thickness of plaque. So OCT is not only limited to ophthalmology, but it has wide-ranging applications in several areas of medicine. Basically, non-invasive method of optically sectioning the eye or the cornea using visible light and not using sound. And the interpretation is based on the reflectance of light that actually comes back into the machine. In the early days, a lot of you probably might not remember the original OCTs that we had in the early 2000s. They were the time domain OCTs. The example is the status OCT that was available then. Later on, the time domain OCTs gave way to Fourier domain and then also called spectral domain OCTs. And more recently, we have OCTs that are also called swept source OCTs. The difference here is that technology and moving parts are very different, but also the speed of imaging is much faster, and consequently you're able to capture many more scans in limited time, which leads you to get high resolution images with less movements of patient's eye. And you also can get 3D reconstruction from the modern swept source OCTs as well. Many systems available in the market. There's no better or worse system. All depends on what you have. Each of them can actually teach or show you something. And you also have a couple of systems that are available for supine OCTs available in the market, the Bioptigen as well as the Zeiss V-Scan OCT. There also are several OCTs available in research labs around the world called ultra high resolution OCTs that can actually give you better resolution than what you can get in the clinic. As of now, these are obviously not cleared by several regulatory agencies because of concerns with the amount of radiation that they will emanate. And so they're used mainly for research and they're not used for clinical use. So what extra does an OCT offer you in addition to what your clinical examination at the slit lamp can? One is corneal thickness. Second is trying to identify pathology in layers. Number three is ability to identify subtle irregularities beneath the surface, planning for different surgeries, especially for lamellar surgery, being able to image behind opaque media, and also to detect lamellar separation. And I'll give one or two examples of each of these. Obviously, we won't cover all of them, but just to show you where it is important. So starting with corneal thickness, it's very obvious that all of you know that we can measure thickness in OCT. But what we found out several years ago when we were trying to measure corneal thickness in keratoconus was that the greatest reliability and repeatability in keratoconus especially was on the OCT as compared to most other devices that we were using to measure corneal thickness, especially in patients with keratoconus. The same is probably true for patients with normal corneas as well. So OCT pachymetry is more reliable as compared to either Scheimpflug or slit scanning pachymetry that you will get on topography machines. What about pathology in layers? There are several layers in the cornea, and actually imaging the epithelium can tell you a lot, especially from the point of view of differentiating tumors that are benign versus those that are malignant or invasive. And OCT has been proven to be very useful for diagnosing the course of OSSN by just looking at the change in the epithelial reflectance and the thickness of the epithelium in various conditions. So very useful to look at the different layers imaged by the OCT. I have to mention that there is some interest in something called a polarization sensitive OCT that is being used a little more for research right now, which is supposed to also give you images of the cornea depending on the biomechanical properties of the cornea based on the polarization of light through the cornea as well. As of now, strictly in research mode, is not used for mainstream clinical use at this point of time. When you talk about pathology and layers after the epithelium, we've also in the past tried to image the Bowman's layer and try to see if we can actually measure the thickness of the Bowman's membrane in patients who have keratoconus. And we found that this actually is a useful modality to diagnose keratoconus by only imaging the Bowman's and not just looking at the epithelium as well. So different layers actually can tell you different things. The second use is planning for lamellar surgery. If you have deposits in the cornea and you can't really make out the depth of deposits, in this case, this is a patient who has granular dystrophy. In this case, you have somebody who has superficial variant of granular dystrophy. You can see how this will help you with planning your surgery by measuring the depth of your PTK when you're planning your ablation for this kind of patient. In addition, you also will use the OCT for planning other lamellar surgeries like DALK if you want to see if the desmase and the duas is involved in the scarring in the slice that is passing through the cornea. Not absolutely predictive because you're only scanning certain slices of the cornea, but certainly helpful when you're planning surgery and discussing with the patient. Additionally, layers under the cornea, say for example, this is a patient with post-PRK haze, you will never be able to see this indentation of the epithelium into that haze and make the decision between doing a transepithelial PTK versus an epithelial removal followed by PTK if you examine this patient only on the slit lamp. And that is where the value of the OCT is brought in from the point of view of planning for surgeries like lamellar surgeries, for Falk as well, like in this case of Danner dystrophy, about deciding the depth at which you need to go down to remove the majority of opacities. I think OCT is fundamentally important. OCT has also helped us in the past in planning surgeries, like this patient who has epithelial ingrowth after LASIK surgery. We were able to very precisely measure the depth of the ingrowth and then actually make a treatment plan where behind the flap behind which the epithelium had grown in, as you can see here, we were able to go in and create a lamellar separation and then remove that lamella and then replace it with a completely new lamella in the cornea. And this would not have been possible if we only looked at the patient in the slit lamp and did not have OCT for planning. So this was the same patient post-operatively. In areas of microbial keratitis, we found that the OCT is not really useful. It cannot help you very much with diagnosis in the majority of conditions. But some interesting findings, like say, for example, confusing conditions like adenoviral keratitis and microsporidia. In adenoviral keratitis, you can image that the inflammation and the scarring is subepithelial, as you can see in this area. Whereas in microsporidia, you can see that the inflammation is mainly intraepithelial, as you can see here. So the OCT can help you in some areas in diagnosing these conditions. In refractive surgery, epithelial ingrowth probably has been one of the most important areas where we've used the OCT, and this will tell you whether the flap is abnormal or you need to do something with the flap or how you control or treat epithelial ingrowth. We won't go into the details here. But in addition, refractive surgery examples here are, this is a patient with a retained smile lenticule, and you can't really diagnose this in the slit lamp unless you have an OCT that tells you about the retained lenticule and also to create your surgical plans. Other areas where it seems to be useful is to study interface haze in this patient after DSEC surgery. Also look for characteristics of interface fluid, because without the OCT, in this patient who had LASIK after Fuchs dystrophy, you have a lot of interface fluid, but you would always miss out on the epithelial ingrowth, which has formed in this flap, below this flap. So that's where the OCT can really help you. Now, the last segment of what I want to speak about is talking about the supine OCT that you will use in surgery. It is not true that you need this OCT in every case, but it certainly is helpful in certain cases. Say, for example, in patients with DSEC, where you think that you've got good attachment of your grafts, when you actually do an OCT, you'll see several gaps in between the graft and the host. And these are gaps that you probably need to take care of to ensure that adherence is better. We, in fact, published a paper that talks about using these gaps and identifying these gaps to actually change your protocols of air injection in DSEC surgery. And so based on that, now we actually ensure that the patient is lying flat for a significant period of time based on the findings on the OCT. Findings in DMEC surgery as well, where you inject your scroll inside the eye, the OCT is very useful in telling you whether the scroll is positioned in reverse or it is positioned in the correct orientation. And in anterior lamellar surgeries, like for this patient who has lattice dystrophy, the OCT also tends to be useful because you know what depth you're at when you're doing an anterior lamellar dissection. And sometimes the OCT can give you some stunning images, like in this patient, where we had a double bubble, as you can see here, and we removed one bubble and there was another bubble that was present between the duas and the Descemet's membrane. And in fact, you can see that bubble in between the duas and the Descemet's membrane. And as we go and remove the bubble, you can actually see the air escaping from that layer. I'm trying to make a small incision. You can see the air escaping and then coming back, and you'll actually see duas, Descemet's, and the bubble in between, mainly to teach anatomy. So this is just an example of where the OCT can be used. There are alternatives like Scheimpflug. There are alternatives like the UBM and the Artemis, but none of them produce as high resolution images as the OCT. And what I think I would like to end with is what the mind does not know, the eye cannot see, which is very, very commonly known. But actually, with the help of an OCT, you actually can see what the mind does not know. So thank you very much again. I'll end there. And thanks again, Ashish, for inviting me to be on your course and for the opportunity to speak today.
Thank you so much, Dr. Praveen. That was a wonderful talk.
Yes,
Moving on, I'd like to call our next speaker. We have Dr. Madhu. Do we have Dr. Madhu? Yes, we do. Sir, if you could unmute yourself and start sharing your screen, please.
Yeah.
Thank you so much. Also, you have 12 minutes, so I request you to kindly please crunch it in time.
Sure. Just a moment. Is my screen visible now?
Yes, it is.
Okay, thank you. So thank you, Ashish, for giving me this opportunity to speak in the corneal imaging innovations. So I'll be covering the topics of advances in specular microscopy imaging and confocal microscopy. So I'll be briefly touching upon the basics. And as we go on, I'll tell what is new in these two fields. There are no financial disclosures. So the scope of this talk would be under the following headings. So if you see, specular microscopy basically is used for diagnosing endothelial dystrophies like Fuchs, posterior polymorphous eye syndrome, and also in preoperative analysis of glaucoma and cataract, and also the specular microscope that we use for eye banking. And also we use it in the follow-up cases of ICL and other intraocular surgeries. So we already have a wide range of specular microscopes that are available in the market. But what are the limitations that this clinical specular microscopes face, and how do we overcome this in the future? So if you see, the limitations right now are the imaging that is done is mostly limited to the central cornea or the paracentral cornea. And most of these equipments are quite bulky. They are not portable. You cannot take it into the field for community screening. And they are quite expensive. They cost around 10 to 12 lakhs, depending upon the make and model that you select. So to overcome this, we have collaborated with the Harvard University, that's the Global Alliance for Medical Innovation, where we have tried to make a slit lamp attachment using a smartphone, which has a proper optical zooming system. And also added to it, we have added an analysis that is developed with the help of artificial intelligence and morphological technique. It's a combination of both. So this results in a low-cost slit lamp-based corneal endothelial imaging platform. So the indications are as it is for what I have done to the clinical microscope. So it is quite simple. You attach this phone to the slit lamp using a 3D printed attachment. And once you go there, like you do your regular specular reflection, if you are able to do this imaging, then you can see the corneal endothelial imaging that you can see in the second Purkinje image, where the beautiful hexagonal is seen. Once it is there, these are the slit lamp settings that we have to put in. It is known to most of you, so I'll just skip that. So once the image is captured, we have developed a smartphone app for this. So once the image is developed, automatically it becomes segmented like this based on the hexagonality into color-coded stores. So once that is done, the patient details are also taken, and immediately within 10 seconds, the process of normalization and smoothing. As all of us know, in the slit lamp imaging that we take, we may not totally have a clear image. So to get a clearer image from that, the pre-processing of the image of normalization and smoothing occurs, followed by identifying the cell borders, that is called as binarization and thinning. So after this happens, the hexagonality, variation, and density of these things are identified. So if you see here, the cost effectiveness of this device is almost, the total cost of the device comes down to nearly 27 to 30,000 when you compare it to a 11 lakh machine that you invest in a clinical specular microscope. And as we are developing it in association with Harvard, we want to give the analysis app for free. You only have to invest on the phone that has a proper optical zooming system, along with a 3D printed slit lamp attachment where you can fit in this phone to get your specular images. So we are in the process of developing the performance of the app. So to do that, we are trying to do the AI approach of ground truths. So what we are trying to do is we are trying to delineate this cell margins with help of an iPad app where we are manually marking the cell margins with a pencil. So the more number of cases we try to do this manually, I think that ground truth helps in giving us a better AI results in the future. So this is how ground truths are generated. And we have published this in the Translational Vision Journal of RO, the official publication recently. So this is briefly about the, I think this is the future of specular microscopes, where you know that you no longer need to depend on a clinical specular microscope. So with the advent of a mobile imaging thing, I think it can be part of every comprehensive ophthalmologist office. Anybody has a slit lamp can directly put it as an attachment and screen for endothelial diseases in a more proper way. And as it is a slit lamp attachment, we can also make it portable and take it to areas where we want to conduct our camps. So next thing is the confocal microscopy. So this is our team from Harvard. I acknowledge their contributions towards making the app. The clinical part we have been doing from our institute. So laser scanning microscopy, as all of you know, resolution may be improved at the expense of field of view. This is exactly what happens in the case of confocal microscopy. So the principle is, when you have a single point of tissue that can be illuminated by a point light source, you get a very high resolution, but literally it will have no field of view. So to solve this problem, the instrument instantaneously illuminates and synchronizes images to get a usable field of view. So in this, we have our whatever when I was doing my fellowship in Aravind, I had the opportunity of working with laser scanning confocal microscopy, which has a very good axial depth of 1 micron. So almost 500 microns of cornea, you can get a volume scan for every 30 microns. So every slice of the cornea you will be able to get. So the equipment that we use there is the HRT3 with the Rockstock cornea module. So this is how it looks. The black one is the Rockstock cornea module. So basically it will help you identify each and every layer of the cornea, right from the epithelium to the endothelium. In epithelium, again, you can get the basal cell layer, Bowman's membrane, nerve plexus, and